loose area Antony B. The Antony A area is normochromic elongated tapered nuclei with modest snowflake cytoplasms with the verrucous bodies. This is peculiar. Most of the time you will see in the scanner, you will report it. Okay, benign tuber or schwannoma. Antony B is loose area cobweb-like network of tumor processes with lipid-laden histocytes and with these thick-walled hyalinized blood vessels. S100 is diffusely staining cell nuclei cytoplasm both. So essential desirable diagnostic is histopathology alone can diagnose this schwannoma. And if you are putting a ISC, S100 is always positive. This is the gross picture of schwannoma, glistening surface, lobulated, well encapsulated. And these are the microscopic feature. You can see these verrucous bodies, the loose myxoid stroma. This is one whirling like pattern. Now there schwannoma there are multiple subtypes, like ancient schwannoma, atypical bizarre nuclei you can get. Like previous the speaker said, not always the atypical bizarre nuclei or malignant. So in ancient schwannoma you can also get this atypical bizarre nuclei. Cellular schwannoma, there will be no Antony A area, devoid of verrucous bodies. Plexiform schwannoma, epithelioid schwannoma, microcytic or reticular schwannoma. This is the another microscopic picture. See this Schwann cells here also, here this is epithelioid schwannoma. See this epithelial like cells. This S100 positivity. This is a cellular schwannoma. See this cellularity. And this S100 positivity. Very cellular schwannoma. Now this neurofibroma. It is also benign. You can see other than Schwann cells, the perineural cell, fibroblast, mast and mast cells with a myxoid or collagenous matrix. It also found under the skin with the smaller nerve, and it is usually asymptomatic. I want to share my experience where I see many patients comes for FNAC of subcutaneous nodules, multiple subcutaneous nodules. Most of the time we do our FNAC myself, we always yield adipocytes. I think I could not follow that patient कि वो एडिपोसाइट जहाँ उसको लाइपोमा लिखो वो तो मस्त होके चला गया, वो ऑपरेट भी नहीं कराएगा unless until it is becomes very large. I don't know how much experience you have, but I never get any spindle cells in this small subcutaneous nodule, multiple subcutaneous nodule, always adipocytes. There is 5 macroscopic form: localized cutaneous, diffuse cutaneous, localized intraneural, plexiform intraneural, and massive diffuse soft tissue type. Microscopy, again, bland spindle cell, thin wavy nuclei. It is a very thin wavy nuclei. You can pick up this one very easily. The nuclei are very thin, spindle and wavy. Myxoid stroma, you can see other than fibroblast, perineural cell and mast cells. If you do a ISC, S100 is always positive. So essential and desirable diagnostic criteria is infiltrative low cellularity spindle cell neoplasm with myxoid collagenous stroma with S100 positivity. Without any mitosis, you can see this level as a neurofibroma. See this microscopic picture, this wavy nuclei. And this is the fibro collagenous stroma. Here you can also see this is the S100 positivity here. This is a cellular neurofibroma. It is CD34 positivity showing these processes. Perineuroma. Perineuroma arises from perineural cell, as I already shown you the previous histology slide. It is very rare and benign. And lower limb, site is lower limb, upper limb and trunk. It is a painless mass and subcutaneous location. It will be again well circumscribed, unencapsulated, rubbery, and you can see the story form of world growth like pattern with slender spindle cell with wavy nuclei and collagenous and myxoid stroma. ISC, EMA and CD34 will be positive. I can show in the next slide this microscopy. See this cellularity, cellularity of the cells, spindle separate cells. Now see this world appearance, this perineuroma, classical around the blood vessels. Here also this collagen stroma, this waviness of these cells. This is the EMA or CD34 positivity. So essential and desirable diagnostic criteria is a story form pattern. Although it is very rare tumor, before reporting perineuroma, you should have done this ISC. Don't report on histopathology alone, morphological diagnosis. A story form world lamellar architecture with slender spindle cell with EMA positivity. Now the malignant peripheral nerve sheath tumor. It is also a very rare tumor, 3 to 5% its incidence, and generally it will give the history of pre-existing benign nerve sheath tumor or neurofibromatosis. You must ask the history. As Dr. Mandal always said, you must interact with the clinician, with the radiologist, with the oncologist, because sometimes recently one patient came for in our department and that was a paramedic. The residents show me the slide. I was not reporting, but show me the slide. Sir, ये slide देख लीजिए. हम ले कह रहे ये तो malignant लग रहा है. हमने history लिया है. I called these paramedics, and there was a huge tumor on the lower limb, and there is history of recurrence. He had 2 surgery in the village. Can you imagine? He is a paramedic working, he is a DMLT student, and he is working in Patna Medical College, and he get operative in a village. And they never did, the village में क्या हुआ, किसी नर्सिंग होम में गया और ट्यूमर निकाल दिया, उसको हो गया तुम्हारा, ट्यूमर चला गया मतलब कि you are now okay. So that's why Dr. Mandal has advised, must take the history. You must see the patient while you are doing FNSE, then you will carry, there is a recurrence. When you did the surgery, you must ask. Then I called this one, I'm like, yes, this is a malignant lesion. So history is very important. So in this case, pre-existing BNST or neurofibromatosis, you must discuss with the clinician. Gross, this fusiform enlargement of nerve Fleshy cut surface will get some areas of hemorrhage of necrosis. Of course, it is a malignant. There will be hemorrhage and necrosis. The vesicle of spindle cells, hemangioperiocytoma like vascular proliferation, and there are two areas, hypocellular and hypercellular. And there will be geographical necrosis. This is very important, geographical necrosis. We will find island of the tumor cell around the necrosed area. And it will sometimes show you this heterogeneous differentiation. Skeletal in malignant peripheral nerve sheath tumor, skeletal muscle, bone, cartilage, blood vessel differentiation. One subcategory is Triton tumor, that malignant peripheral nerve sheath tumor with a skeletal muscle differentiation is called Triton tumor. And you will get S100 and SOX10 positivity in this. So essential and desirable diagnostic criteria for diagnosing this malignant peripheral nerve sheath tumor is sarcoma from a nerve or pre-existing nerve sheath tumor. You must ask the history, it will give a history. Spindle fascicular growth and geographical necrosis. You must think of malignant peripheral nerve sheath tumor, and you can write, you can sign out with this S100 or SOX10 positivity ISC. See, this is the gross picture of this malignant peripheral nerve sheath tumor. Areas of hemorrhage and necrosis, large tumor. And this is the microscopic hypocellular area, cellular area. See this spindeloid cells with wavy pattern. See the nucleus look like some waviness of pattern. And this is the bizarre tumor cells. And this is one Triton tumor. Triton tumor with this rhabdomyo, differentiation. This is eosinophilic cytoplasm. So now the second thing, on the cancer awareness or no tobacco. I have, when I joined as head of the department, I made a notice our entrance no tobacco zone. Nobody can eat tobacco in our premises in the pathology department. And even the principal office staff, they are so scared of me. If sometimes they are making khaini, they will run away. Even in the eco park, eco park जो पटना में है, वहाँ पर जितने भी दरबान है, they use in the morning they start this खैनी. हम लोग I have said, अरे च्यवनप्राश खा रहा है तुम लोग सुबह सुबह. तो उन लोग अब एकदम मुझे देखेगा तो भाग जाएगा या तो छुपा लेगा या खाना बंद कर देगा. तो you should spread this. We can prevent 50% of the malignancy by creating awareness. So this was on the World No Tobacco Day. I called our respected teacher, Professor Hai, to deliver a lecture on this our Patna Medical College. Both Sweta are here. They did the anchoring. Oh, that is the picture of World No Tobacco Day last year. This is our batchmates. We recently had been to Tata Tata Main Hospital, Nuamundi, Jharkhand. This is Dhirendra Bose, our immediate senior. He is the CMO there. He asked me, Dilip, you come with your friends, you do a cancer awareness program. So R.N. Tagore, this is my friend oncologist, Dinesh, Rakesh, Arun, Dhirendra Bose. We went there, Nuamundi. We did a cancer awareness program there. Just to show this picture, so that since morning you are going through the vast lectures of this ISC, atypical cases. So these are the just filler. We made T-shirts. And Patna Medical College 81 batch, this boss is senior 80 batch. So these things we do 3 or 4 times in a year. Now the last section is the blood vessel, tumors and tumor-like condition of blood vessel. Hemangioma. Actually, hemangioma is not a neoplastic because this lack the chromosomal alteration. But it gives neoplastic effect because of the localized and masked effect. This is not a neoplastic lesion. Classification depends upon the clinical appearance and caliber of the vessels. Capillary hemangioma, I think nothing more to say. It is small vessels of any organ, it can occur.